Welcome, everyone. My name is Ted O'Connell. I'm one of the authors of Crush Step 1, the ultimate USMLE Step 1 review. This is the second edition of the book, and we're going through it chapter by chapter. This is part 8 of the cardiology chapter. We're going to start by talking about congestive heart failure. Heart failure is the inability of the heart to supply sufficient blood flow to meet the demands of the body, causing specific symptoms and signs depending on which side of the heart is affected. Heart failure can occur from either or both of two types of dysfunction, systolic dysfunction and diastolic dysfunction. Systolic dysfunction is a problem with ejection of blood during systole, characterized by a low ejection fraction, which is normally 55% or more. There's no problem in filling. The heart is full, but cannot eject the blood that it needs to. This can be because the heart either cannot contract well, poor contractility, secondary to ischemia or infarction or cardiomyopathy, or because it's contracting against too great of an afterload, such as aortic stenosis or severe hypertension. Diastolic dysfunction is a problem with filling in diastole, typically with a preserved, normal or near normal ejection fraction. This is typically due to a stiff ventricle, either from hypertrophy, fibrosis, or restrictive disease, such as restrictive cardiomyopathy or pericardial tamponade. In this case, the stiff ventricle cannot relax enough to fill adequately, but the ventricle can eject the little blood it receives without difficulty. Heart failure can also be divided into left heart failure, right heart failure, and biventricular failure. Left heart failure occurs when the left ventricle cannot eject sufficient blood into the aorta, causing the blood to back up into the lungs, producing pulmonary edema. Systolic dysfunction from ischemia and myocardial infarction is a common cause of left heart failure, although diastolic dysfunction can occur as well. The higher pressures in the pulmonary system lead to increased afterload for the right ventricle, which can subsequently lead to right heart failure. Most of the manifestations of left heart failure are symptoms rather than signs. Pulmonary edema. Transudation of fluid into alveoli due to increased hydrostatic pressure in the pulmonary capillaries because the left heart can no longer pump that fluid out. This fluid also causes the physical exam finding of bibasilar inspiratory crackles because inspiration forces air into fluid-filled alveoli that are edematous. Often, there may be small hemorrhages, which is why patients with pulmonary edema often cough up a pink, frothy liquid. Macrophages eat the blood hemorrhaged into the alveoli, but retain the hemosiderin. Microscopically, these hemosiderin-laden macrophages, called siderophages, are called heart failure cells. Orthopnea. This is difficulty breathing while lying supine, owing to increased venous return because gravity is no longer impeding blood from returning to the heart. This exacerbates the volume overload because the left ventricle cannot pump the added fluid, leading to worsening pulmonary edema. Often, patients will sleep with multiple pillows, propping themselves upright in an attempt to reduce venous return to the heart. Paroxysmal nocturnal dyspnea, or PND. This also causes difficulty breathing while lying supine, but takes hours to occur, usually after the patient has fallen asleep. Unlike in orthopnea, when blood already in the vasculature returns to the heart, in PND, the interstitial edema outside of the vasculature reaccumulates into the vasculature and returns to the heart. An S3 or an S4 sound. The S3 sound, as previously discussed, occurs during the rapid filling phase of diastole and is a marker for fluid overload. The S4 sound occurs when the atrial kick attempts to force more blood into a stiff or overfilled ventricle. Both sounds can be present in left heart failure. Now let's talk about right heart failure. Right heart failure occurs when the right ventricle cannot eject sufficient blood into the pulmonary artery, causing blood to back up into the rest of the body, not the lungs. It is worth noting that the most common cause of right heart failure is left heart failure. Left heart failure causes fluid overload in the lungs, increasing the afterload for the right ventricle, eventually contributing to the failure of the right ventricle. When the right ventricle fails due to pulmonary hypertension in the absence of left ventricular dysfunction, it is termed cor pulmonale. Examples include increased pulmonary resistance or afterload from destruction of pulmonary vasculature from lung diseases such as chronic obstructive pulmonary disease, obstructive sleep apnea, or blood clots blocking branches of the pulmonary artery. These are called pulmonary emboli. Rather than symptoms, most of the manifestation of right heart failure are signs. Jugular venous distension is a backup of blood from the right ventricle that moves into the right atrium and the veins feeding it. The increased venous hydrostatic pressure can be measured at the internal jugular vein. Edema. The increased hydrostatic pressure also forces fluid out of the capillary beds into the interstitial tissue in the periphery, similar to how increased pulmonary hydrostatic pressure in left heart failure causes pulmonary edema. Usually, the edema is dependent, meaning it occurs in the areas where gravity further increases hydrostatic pressure, the ankles for those sitting upright, or the sacrum for those supine. Hepatomegaly. Because the hepatic veins drain into the vena cava, blood will back up into the liver as well, causing liver congestion. In severe cases, this can cause ascites or even cirrhosis if the pressure in the liver impedes portal vein drainage into the liver. Because the now congested liver holds much blood, the physical exam maneuver hepatojugular reflux can be used to accentuate the JVD in those with heart failure. This hepatomegaly can be painful. Now let's talk about the cardiomyopathies. There are 3 cardiomyopathies: dilated, hypertrophic, and restrictive, in order of decreasing prevalence. Any of these can cause symptoms of heart failure, which is described previously. Dilated cardiomyopathy is the most common, accounting for 90% of cases. The etiology is most commonly idiopathic, but can also be due to alcohol or drugs, both illicit drugs such as cocaine, as well as medications such as the chemotherapeutic agent doxorubicin. Can also be caused by pregnancy or after myocarditis, most commonly from viral myocarditis from Coxsackie virus, but also from Chagas disease from the Trypanosoma cruzi. Findings include a globally dilated heart called eccentric hypertrophy, with poor contractility leading to systolic failure, meaning low ejection fraction. Dilation of the valve ring seats causes valves to no longer line up correctly, leading to mitral and tricuspid regurgitation. Poor ejection leads to fluid overload, leading to an S3 heart sound. Typical symptoms of heart failure are present. Treatment. Medical therapy is similar to congestive heart failure, but cardiac transplantation may be necessary if it is refractory to treatment. Hypertrophic cardiomyopathy, previously called idiopathic hypertrophic subaortic stenosis, is a common cause of syncope and sudden death in young athletes and in those with Friedreich ataxia. Etiology is most commonly familial with autosomal dominant inheritance. Findings. There is asymmetrical hypertrophy near the ventricular septum, concentric hypertrophy, leading to possible obstruction of flow out of the left ventricle. The narrowed outflow tract leads to a Venturi phenomenon, in which the high velocity of blood being ejected through the narrowed opening causes the anterior leaflet of the mitral valve to be pulled toward the septum during diastole, termed systolic anterior motion of the mitral valve, and this closes the outflow tract. The narrowing also causes a systolic crescendo-decrescendo murmur similar to that of aortic stenosis. An S4 heart sound is also common in hypertrophic cardiomyopathy. The intensity of the murmur of hypertrophic cardiomyopathy is inversely related to the preload. Increased preload causes the ventricle to fill more, increasing the diameter of the outflow tract and therefore decreasing the intensity of the murmur. A poorly filled ventricle will have a much more narrow outflow tract and a louder murmur. The Valsalva maneuver, forcible exhalation against a closed glottis, causes a transient rise in intrathoracic pressure, which prevents venous return, causing decreased preload and a more harsh murmur. Squatting compresses lower extremity veins, increasing venous return and thus preload, decreasing the murmur intensity. Standing will cause venous pooling from gravity and decrease preload. This concept is important because the murmur sounds similar to that of aortic stenosis, but in aortic stenosis, the increased preload leads to a louder murmur, more blood being ejected through the stenotic valve, whereas in hypertrophic cardiomyopathy, the increased preload leads to a softer murmur. Larger ventricular volumes lead to a larger outflow tract and less obstruction. Treatment: ensuring that the ventricular chamber volumes are always relatively high to lessen the obstruction. Therefore, beta blockers or calcium channel blockers are used to ensure that the heart rate does not increase, which would decrease filling time and lead to smaller chamber volumes, and that the contractility does not increase, which would lead to smaller ventricular volumes from increased stroke volume and worsening obstruction. Restrictive cardiomyopathy is characterized by rigid, non-compliant ventricles, which may be able to contract normally, normal systolic function, and therefore normal ejection fraction, but they cannot fill correctly owing to their rigidity. Etiology is most commonly amyloidosis, a systemic disease in which abnormal proteins are deposited in the body's organs and can be detected on biopsy with a Congo red stain, which demonstrates apple green birefringence. In addition, sarcoidosis, hemochromatosis, and post-irradiation fibrosis are common causes of this uncommon cardiomyopathy. Findings: symptoms of heart failure are present. Fibrosis of the conduction system can lead to arrhythmias. Treatment: unfortunately, there's no treatment for restrictive cardiomyopathy except to treat the condition responsible for it. Treatment of volume overload with diuretics can be beneficial for symptomatic relief. That's the end of this section. In the next, we'll start with rheumatic fever.